Good morning. I think we're going to get started in part because Bob told me he had a lot to cover and to keep it short. So I don't want to take a lot of time or start too late. So it's my pleasure today to introduce Bob Kerns, who is a clinical psychologist and professor of psychiatry, neurology, and psychology at Yale. The hallmark of Dr. Kerns' career has been his long-standing interest and commitment to improving pain care, a really timely issue at this point in the United States. As evidence of his recognition as a thought leader, he's held many influential positions, including membership on the Institute of Medicine's Committee on Advancing Pain Research, Care, and Education, as chair of a work group on the development of the National Pain Strategy, and chair of a federal interagency work group that developed a national action plan for prevention of opioid-related adverse drug events. He has a strong record of federally funded research on pain management and is the author of over 200 original peer-reviewed publications, books, and chapters. His most important contributions focus on a wide range of topics related to pain, including comprehensive pain assessment, non-pharmacological approaches for the management of pain, which we'll hear about today, individual differences and disparities in pain care, safe and effective opioid therapy, the design and conduct of pragmatic pain trials, and promotion of the organizational improvements that are needed for pain care. So with his lecture today, we will have the opportunity to benefit from Dr. Kerns' wisdom and experience in pain management. So with this, please join me in inviting Dr. Kerns to the podium.
Well, good morning, everybody. Thank you for coming. And this truly is a passion for me. I have, a 40-year career to talk about in about an hour. So I'll just be nibbling at the edges of things that I think are important about what we're trying to do in this country to improve pain care and maybe indirectly have some impact on the opioid epidemic as well. I have multiple sources of funding, a couple of disclosures about consulting that are relatively relevant today. And I also want to acknowledge that I also continue to have an appointment at the VA, and what I have to say has nothing are my opinions, not those of the Department of Veterans Affairs or the government. So these are my parents, now deceased. My mother, who loved the Big Bang Theory, and the mother of Sheldon, who would always say, "We'll see," and always kept me in line in that regard. My father, Robert Daniel Kerns Sr., a clinical psychologist, one of the first clinical psychologists in this country to have graduated from University of Pittsburgh, ended up being a public service psychologist and played very instrumental roles in the state of West Virginia in transforming the delivery of mental health care in that state. And I'm very proud to be his offspring. My mother, registered nurse, I think always wanted me to be a doctor. And so somewhere along the line, and probably at a pretty early age, I really appreciated that my destiny was to end up being a public service psychologist in an academic medical environment. Oh, that's right, I really wanted to be a cowboy. So here's a little trip down memory lane. I was born in Pittsburgh, raised in West Virginia, where my father moved us when I was relatively young. I went to West Virginia University, Southern Illinois University, and then actually arrived here for a one-year psychology internship at that time, the West Haven VA Medical Center in 1978 in clinical neuropsychology. And the rest, they say, is history. It was at WVU that I got to know this guy, B.F. Skinner, and set down my roots and foundations as a rabid behaviorist. At the time, probably in some ways rejecting my father's psychoanalytic roots and training, I found a home there in terms of understanding the importance of the social environment and context in terms of understanding human behavior. And as Skinner said, the major difference between rats and people is that rats learn from experience. This was the lab at Southern Illinois University, and in the middle is Steve Haynes, not to be confused with Steve Hayes, the founder of acceptance and commitment therapy that some of you may know. So I gravitated to Southern Illinois University in a program called bioclinical psychology, kind of the interface between psychology and health and illness issues. And there I am, actually, in my hippie days. So I gravitated, of course, to the one true behaviorist in the department. I knew he was a behaviorist because he had a pet goat named Burris, named after B.F. Skinner's. It was actually at Southern Illinois that I was first exposed to this gentleman, Albert Bandura, and the concepts of social cognitive theory and the principles of behavior modification became my guiding source, if you will. And it's in this context that the concepts of self-efficacy and self-promotion, self-management really started to emerge in my thinking. Then I came here to Yale and VA Connecticut, and for some old-timers in the room, you may see a few familiar faces, several now deceased, people like Graham Gibbard in the front row, Dom Cicchetti, Larry Hemmendinger, Betsy Brett, Jack Levine, Ed Ryan, Jonathan Marcus, Walt Needham, and there's me up in the corner again, Dick Delaney, my mentor here at Yale and VA Connecticut. Turns out I stayed a little longer than 1 year, and I have a whole series of pictures as we grew up together in those ages. Morris, are you in there? I don't think so. You must have missed that slide. It was here in that very first couple of years that I met Dennis Turk, who was a brand new assistant professor in the psychology department at Yale, who had this crazy idea that maybe thinking had something to do with pain. And he was coming from a lab doing laboratory analog research on this idea that people, if they were more anxious, for example, or were prompted to think negative, what we now call as catastrophic thoughts, they would pull their hands out of ice water more quickly than people who were thinking more positive thoughts or in a more positive mood in the setting. Dennis, taking the behavioral concepts that were advanced at that time by others in the field and thinking about pain behavior, is here demonstrating a good low back pain behavior. And it was at that time in 1983, actually, that he published his seminal book that took him around the world talking about this idea about social cognitive theory, cognitive behavior therapy for chronic pain. And Dennis and I, actually, in my first year as a faculty member here and as a staff psychologist at VA Connecticut, working to build a clinical health psychology enterprise on that campus, wrote our very first grant together to really see if a treatment approach based on cognitive behavioral therapy principles could be applied and help people with chronic treatment refractory pain. And lo and behold, it was funded, and I've had the good fortune of continuous funding from VA and now other sources ever since. And it was at that time that I was introduced to this fellow, Wilbert Fordyce, really, some would argue, one of the founding fathers of the field of pain management, a psychologist who specifically promoted the idea of a multidisciplinary treatment approach to chronic treatment refractory pain. That both, at that time, opioids were bad before they were good, before they were bad again. At that time, the focus of the program really was on helping people taper their opioids or other pain medications while being reinforced for well behavior, activities, exercise, and so forth, and really using behavioral principles. Pain behaviors, as Dr. Turk showed in the previous slide, were ignored, given time out, so to speak. So Fordyce really, I want to say, was important, and I've been privileged to be honored with an award from the American Pain Society in his name. So all that is by way of saying I like to think about what I do and my contributions to the field as being grounded in theory and theory-based evidence. And this leads us to another context that I'd like to place what I have to say in. We now are faced with what I would talk about as two interwoven public health crises. One is the extraordinary high prevalence, costs, and disparities related to pain care and pain itself, and the opioid epidemic. I'm going to kind of set aside the opioid epidemic for the most part in my talk today. As Stephanie mentioned, I am involved in national efforts, really not by really choice, but kind of being a pain expert, getting dragged into the opioid crisis as well. And it's gratifying that I now am interacting quite a bit with people in this department and other departments in the school here in the substance use arena as well. And only recently had the privilege to talk to the Division of Substance Abuse, giving a talk about pain care, more specifically focused on the opioid issue, and also a presentation in an internal medicine, addiction medicine rounds only a couple of weeks ago. So today I'm really going to focus on the pain side of this equation. So this is a reference to a very important committee on which I was privileged to serve, which Stephanie acknowledged, which was a 19-member Institute of Medicine committee that was designed to really label the pain problem as a public health problem, and to lay out a framework and a series of findings and recommendations to really try to move the field forward. That led, actually, or coming out of the IOM committee, was a recommendation to the Secretary of the Department of Health and Human Services to develop a national pain strategy, a comprehensive approach to addressing pain, education, care, prevention, and research. At that time, the Secretary of Health and Human Services chartered another group that had been legislated by the Affordable Care Act, called the Interagency Pain Research Coordinating Committee, to take on this task of developing the national pain strategy. And it was assigned to leadership in the National Institute of Neurological Disorders and Stroke. It was organized around 6 chapters, if you will, and I was privileged to serve as the co-chair of a work group on service delivery and payment, which is kind of interesting given that my whole career had been in the VA, where we really didn't pay that much attention to money. But nevertheless, I've come to understand that's where the action really is. And again, I won't talk so much about that, but I think you'll get the point. So the National Pain Strategy actually is an important foundational framework for thinking about what I'm going to talk about today, because in fact it explicitly talks about the findings and recommendations that encourage a reshaping of the way we think about pain care broadly speaking, and in that context highlights the construct of pain self-management, which I'm going to emphasize today. And the National Pain Strategy itself then was followed up with through the Interagency Pain Research Coordinating Committee, the development of a very recently published federal pain research strategy that's organized around these areas on the bottom of the slide. Prevention of acute and chronic pain and acute pain management, the transition from acute to chronic pain and chronic pain management, and disparities in pain and pain care. And I worked on the chronic pain and chronic pain management work group. It's that set of recommendations now that I think has already started to percolate its way into organizations like the National Institutes of Health and the Department of Veterans Affairs in guiding our ideas about where research priorities should be. So all that is by way of a context. One other context is the enormity of the problem, framing it as a public health crisis itself. So the Institute of Medicine took the bold step of commissioning a epidemiology group that came back with a report that suggested that approximately 100 million Americans report the experience of chronic pain. That immediately led to some pushback about that, and in fact that has advanced our field by encouraging the isolation of a new construct to the field, high impact chronic pain. It may be that 100 million people, look around the room, maybe a third of the group here today experience some persistent or chronically recurring pain condition. But we're here, we're functioning. It's probably a much smaller minority, but still a large number of people who have a chronic pain problem that is interfering with their daily lives, their participation in social role activities and productive lives. So we now have this construct of high impact chronic pain that's been kind of grown from putting this number out there and then having people react to it. It's widely understood that some chronic pain conditions, low back pain, headache, osteoarthritis, are some of the leading contributions to disability in this country and, in frankly, around the world. And there are many other chronic pain conditions that individually, but certainly together, have a significant impact in our the livelihood of our societies. They estimated from this same commission report that pain costs this country every year $500 billion. You know, on the one hand, it's limited. There are limited data that were available to produce this number, but it probably is at least that much, if not more, because this number only takes into account costs related that we could obtain from claims data or other data related to healthcare system use, presumed costs associated with over-the-counter medication or other kinds of care, or disability or other estimates of declining productivity. And finally, to support the notion of pain being a public health problem, the IOM report itself, and now really following on its heels, many other papers have highlighted disparities in pain prevalence and care across the usual suspects: gender, age, race, education, literacy, and importantly, I think we're zooming in more on the issues of wealth disparities in this country as huge challenges for understanding pain. In a recent paper, which Alicia Heapes, who's in the audience, actually acknowledged that a very strong association, particularly between low income, low wealth in this country and particularly high prevalence of high impact chronic pain. And I cite similar statistics about the VA because I'm going to talk a lot about my VA work. And here, you know, everything that's on the left side of the slide is true in spades when we think about military veterans who were in the IOM report were specifically called out as a particularly vulnerable group. And for this audience in particular, without citations, because it's a very large literature, which I've contributed a little bit, we understand that pain is highly comorbid or multimorbid with mental health and substance use disorders as well. And we have growing evidence that pain is a significant moderator of the effectiveness of our interventions in the mental health sphere, including, for example, the efficacy or effectiveness of antidepressant therapy for people with depression. And here's just one pretty slide that cites something that I find important and interesting to think about. Everybody in the room knows that the cardinal problems, if you will, of the recent wars in Iraq and Afghanistan are PTSD and traumatic brain injury. But this slide would beg to differ to a certain extent. So these are a small group of patients at the VA Boston healthcare system who screened positive for the presence of a traumatic brain injury, who were then evaluated clinically in a specialty TBI clinic, and were found. What we found was that the largest proportion of these patients had all three conditions at the same time, including chronic pain, PTSD, and traumatic brain injury, and very few people in the sample, veterans in the sample, had either PTSD or TBI alone. So back to the IOM, the National Pain Strategy, and the Federal Pain Research Strategy, they all suggest that we have a significant problem. There's a disconnect between the significant burden of pain and the availability of effective programs, services, interventions due to the fact that they're not available at all, or to the extent that they're available, they're not accessible, or they're not reimbursed and grossly underutilized. And so this really serves as a foundation for what I'm going to now speak about through the rest of my talk. And this laid out through the Federal Pain Research Strategy one of the top priorities, which was to develop, evaluate, improve models of pain care, and suggested that research is needed to develop new and improve on current models of primary, secondary, and tertiary care to improve pain management across the continuum of the pain experience, from acute pain to pain at the end of life. Research should include studies of models of integrated care, team care delivery, and particularly focused on reimbursement innovations that are necessary. All that to determine the benefits, risks, and costs of pain treatment, and specifically to assess both the effects of policy changes on pain care and to influence policy. So taking that one step further or backward, depending on how you're thinking about it, from the National Pain Strategy, this concept of an integrated, patient-centered, evidence-based, multimodal, and interdisciplinary pain care approach, just rolls off the tongue, I think, is the evidence would support that kind of perspective. And so, in fact, it takes me back to my roots at VA Connecticut, where very early, when Dennis Turk and I were starting to plow the ideas of cognitive behavior therapy, we were doing that in the context of what we called the Comprehensive Pain Management Center, designed to be an interdisciplinary clinical research and training program for veterans with chronic pain. So this was in 1980, and here we are, 2018, still struggling with the same issues. This is a picture of the more recent shot of the integrated pain team, led by John Sellinger, a clinical health psychologist, director of that program at VA Connecticut. And importantly, I like to note that involves a multidisciplinary team, including veterans themselves as part of the team. So this is the idea of an integrated care approach that involves a systematic coordination of various specialties or disciplines and addresses this problem from a biopsychosocial perspective. So we think about a biopsychosocially informed multimodal treatment approach. We've always thought that way, at least in my lifetime. And this is a slide adopted from Steve Dobsha, who actually gave rounds here a couple of years ago, a psychiatrist who was trained here in part and then has established his career at the Oregon Health Sciences University Center. The concept of a biopsychosocial model really applied in terms of the need for integration of behavioral approaches, pharmacological approaches, and physical modalities, all in the service, all occurring in the context of an integrated health system that promotes healthy behaviors and addresses comorbidities, and that emphasizes, in particular, self-care and self-efficacy. And you know, pain treatment is a little more than snap out of it. This is a slide from an early work that I did applying an operant conditioning model and the construct of punishing or negative responses to pain actually having some benefit. in terms of helping to reduce people's experience of pain and disability, unfortunately also likely to be associated with increased affective distress. Or it's either that or it's Cher and, I forget the other, in Moonstruck or whatever, when he says, I love you, it always reminded me of that. But anyway, the bottom line is that we really think about pain care informed by a biopsychosocial model being one in which there are multiple goals, well beyond just pain reduction itself and analgesia. So it starts with actually identifying and managing as best we can the underlying painful condition. And now, from the IOM report moving forward, I think we think about some chronic pain conditions being chronic diseases themselves. So a new idea, new labeling. But the bottom line is that that's important, and then we can think about reductions in pain intensity, but we also have an increasing emphasis, and many would say the primary emphasis needs to be on optimizing functioning, productivity, improving or reducing emotional distress, and improving overall quality of life. And this fits really well into a model that probably many, but not all of you know about, the Wagner chronic disease management model, or the chronic care model, that really emphasizes the important ways in which, health systems can interact with community resources, and all in the support of supporting productive interactions between prepared, proactive practice teams and informed and activated patients. And again, highlighting the important role of patient activation and the importance of pain self-management support. So back to the recommendations of the IOM report from our section on the care of people with pain. The number one recommendation from this group was that healthcare provider organizations should promote and enable self-management of pain as a starting point for management. All of this should occur by also addressing the barriers to care that exist in our culture and climate and healthcare systems to date. The important role of filling a gap in terms of educating healthcare professionals well beyond physicians, to include nurses, psychologists, and other healthcare providers. The importance of really fostering better integration and collaboration between generalists and pain specialists, particularly in the primary care setting, but beyond as well. And then finally, that we should be addressing issues related to reimbursement policies and issues about how we can incentivize the model of care that we all envision for addressing this public health crisis. And back to, starting on to zoom in on pain self-management itself. These are really from thinking about really where we place this kind of initiative in the current cultural zeitgeist around self-management and self-management of chronic disease much more broadly. So we have very limited evidence to support many of the interventions that we have in our toolbox now for managing chronic pain, but frankly, even acute pain and pain at the end of life. And the potential basis for that is because of the failure of a purely biomedical reductionistic model and thinking about pain as a purely sensory phenomenon, and the need to apply a biopsychosocial approach. We have limited evidence of the traditional medical and surgical approaches. At the same time that I was writing about evidence-based reviews, which I'll cite in a minute, about the efficacy or effectiveness of psychological interventions, several colleagues here in this department and at Yale published a review of the evidence of opioid therapy for the management of low back pain and found virtually no evidence to support the use of long-term opioid therapy for that indication. And of course, as I've already said, this is in the much broader context of thinking about self-management of other chronic diseases. So if we think about the public health burden of pain and we think about pain and chronic pain in particular as a chronic disease, then potentially similar kind of approach may apply. And it's the impact of the National Pain Strategy has already been felt by the incorporation of developmental objectives within the Healthy People 2020 and moving toward Healthy People 2030 objectives, a major national health initiative in this country, with a developmental objective that focuses on these 4 topics, including the focus on increasing self-management of high-impact chronic pain. So what do we mean by a patient-centered approach to pain self-management? Well, I think I'd like to assume that I've established that it's important to think about it in a chronic illness or chronic disease model. It's the idea of empowering persons with pain through reassurance, encouragement, education in particular, potentially the conservative use of analgesic and adjuvant medications, co-analgesics, if you will. But importantly, even here, as we think about chronic pain management, the same with chronic cardiovascular disease management, diabetes management, the promotion of regular exercise and healthy active lifestyle, more general focus on promoting healthy behaviors and decreasing risky health behaviors is important in this domain as well. And I'll show a little bit about that later. And finally, where my work fits in is this development of adaptive strategies for managing pain. So when I was young, back to Dennis Turk and our first study, we published one of the first studies of cognitive behavior therapy, randomized controlled trials of cognitive behavior therapy for the management of a heterogeneous population of people with chronic pain. Cognitive behavior therapy, as it's been applied to depression, anxiety, other problems, is very similarly applied to chronic pain. It really is a structured, goal-oriented, time-limited approach that focuses on reconceptualization of pain as a problem to be solved, the presentation of opportunities for new skills, we might say adaptive pain coping skills to be learned and practiced and acquired, and ultimately the objective is to promote adoption of an effective approach to pain self-management. There are other core principles here. The pain principles that are we try to instill in the recipients of the treatment. The pain treatment involves management. It's not a cure. That it's important to set realistic goals that are all in support of promoting and really reinforcing concepts of pain self-efficacy, and really that the effort is not just on focusing on reduction of pain, but it's focusing on improving functioning and improving likelihood of achieving value-based behavioral goals. It's important also for people to, I think, to understand that from my way of thinking, this all has to occur in the context of a supportive, respectful, compassionate, and understanding therapeutic relationship, and with an explicit focus on therapists having a role as effective behavior change agents, and also that it is attentive to core principles of sound behavior change, such as goal setting and intersession skill practice and effective use of social reinforcement. This was published in a paper with colleagues Mark Jensen and Warren Nielsen now, I guess, about 15 years ago. The key here, I think, is that as, I won't talk about this much later, but as we've tried to study mechanisms of change in the context of cognitive behavior therapy for chronic pain, we understand that therapeutic alliance and self-efficacy are equally important general driving mechanisms as anything more specific about the strategies that we employ in CBT for chronic pain. And from our very early work, we developed actually a strategy for helping patients identify and use their own personally meaningful behavioral goals to help drive or motivate their engagement in treatment. I'm reminded of a patient who was mid-age, in his 50s, with two young adult children. And his goal for he had been debilitated for many years. Essentially had become bedbound with a fused knee, low back pain, polypharmacy that left him very sedated, cognitively impaired, and so forth. His goal was to be able to walk his daughter down the aisle at her wedding that was scheduled for a year later. And in fact, over a very intensive round of therapy, well beyond cognitive behavior therapy alone, a lot of physical therapy and truly an engaged interdisciplinary team, he actually succeeded in that goal. So the bottom line is really back to these theoretical foundations and core behavioral principles. From my point of view, helping people identify specific, meaningful goals and helping them to work to achieve their goals is really an important target. And we'll talk a little bit more about that later as an additional foundational approach to promoting pain self-management. And of course now, many years later, 30, 40 years later, we have evidence to support multiple psychological or behavioral interventions that have demonstrated efficacy, even effectiveness, and in some cases demonstrated cost effectiveness for the management of chronic pain more broadly and specific pain conditions like low back pain, headache, and several others. And these include supportive psychotherapies, self-regulatory treatments, frankly, behavioral treatments, particularly family or couple treatments that focus on patterns of communication within the family, as well as cognitive behavior therapy. And so again, just as the time we were starting to publish about the limits of opioid therapy or other kinds of interventions that are commonly employed and reimbursed in the management of pain, we were providing good summary evidence of the efficacy of these kinds of a broad array of psychological and behavioral approaches. And in one published meta-analysis, in fact, we found an overall omnibus effect, small as it was, but for any treatment containing a psychological intervention, when contrasted with any control condition, including active controlled conditions, on any outcome measure, pain, functioning, depression, and across all time points, even up to 5-year follow-up data, we found support for a significant effect of these kinds of psychological or behavioral approaches. And here's one slide to highlight just a few of the more specific findings showing even moderate to large effects of psychological interventions such as cognitive behavior therapy or what we called self-regulatory treatments, biofeedback, hypnosis, relaxation, or mindfulness-based stress reduction on pain or even depression. Full speed ahead, most recently in November of 2016, the VA sponsored a state-of-the-art conference on non-pharmacological approaches to chronic musculoskeletal pain management to answer two main questions. What is the evidence that would support full implementation, that is, through policy, endorsement, practice guidelines, the implementation of non-pharmacological approaches and promoting their equitable and timely availability for all veterans regardless of their point of care? And the second question is where are the evidence gaps and what is the important research agenda moving forward? And this slide summarizes what the group, an expert panel, decided were the finite number of non-pharmacologic approaches in 3 buckets: manual therapies, behavioral psychological therapies, and exercise movement therapies, all of which have ample evidence to support their routine availability in the VA, and I would suggest in the broader community, health system community. It's important for me to emphasize that all of these approaches clustered near the bottom around behavioral psychological therapies, exercise movement therapies, are those that are consistent with promoting self-management. These are all about teaching people skills that then they can apply and practice in their use in their everyday lives, as opposed to approaches maybe that are considered manual therapies that are equally effective, such as acupuncture, massage, going to a chiropractor for spinal manipulation, that also have evidence of effectiveness, but are those that are maybe more passive, if you will, and require continued visits with a healthcare provider. What we lacked when we held this conference, which I was privileged to co-chair, was evidence review about the models of care for chronic pain management that we could apply, in which we could frame these non-pharmacologic approaches. So what's the evidence for the most appropriate model of care delivery, back to addressing this broader question raised by the IOM report, the National Pain Strategy, and the Federal Pain Research Strategy. So we chartered or commissioned a evidence synthesis review by a group that's set up in the VA to do this through the Quality Enhancement Research Initiative, and they came forth with their report that's now actually in press in a soon-to-be-released issue of the Journal of General Internal Medicine. And the bottom line of their review was that of 11 articles, 10 studies focused on models of pain care delivery. Most were RCTs of at least fair to good quality. They had 12-month, on average, 12-month follow-up. Most used a usual care control condition, and they found significant benefits on a number of measures, including pain intensity, pain interference, and emotional well-being. Ultimately, without getting into the specifics of the models, which overlapped quite a bit, the key here is to understand what they also identified as some of the core ingredients or components of these models of care. And importantly, they were decision support to enhance provider education and treatment planning, additional care coordination resources, which they highlighted in particular may be the core or the key ingredient among even all these other ingredients. Increased access to multimodal care, that is the need to promote equitable and timely access to these care delivery systems. And for the purposes of this slide, this talk, I want to highlight this focus on improving patient education and patient activation. So we have some evidence about the effectiveness of these models of care and what kinds of components really are the most important components to integrate and think about as we move forward. And of course, full speed ahead to thinking about reimbursement and incentivizing these models. It's how do we actually build models of care that are viable, not just in integrated healthcare systems like the VA, where many of these trials were actually conducted, but in the private fee-for-service environment as well. However, having acknowledged this, they and others also highlighted key targets for improvement. These really overlap quite a bit with the findings and recommendations from the National Pain Strategy, our review of the evidence for psychological and behavioral treatments for chronic pain. It's really all the same. In my lifetime, it seems like we've hit a ceiling in terms of positive effects. So we do want to keep working to try to develop new mechanism-driven, innovative approaches to pain care themselves that can actually break through that ceiling, so to speak, in terms of beneficial effects to the people that are receiving these treatments. But while we have all these treatments that are known to be effective or even cost-effective, there are issues that we need to address related to access, patient engagement, reducing patient dropout, and enhancing adherence to treatment recommendations. And then all of that may actually ultimately be important in driving maintenance of treatment gains and promoting relapse prevention. So let's focus a little bit on the issue of how do we promote pain self-management itself. So what do you think? Should we get started on that motivational research or not? So this took me now actually 2 decades ago to thinking about another theoretical context, which was Prochaska and Di Clemente and others' trans-theoretical model of behavior change, and particularly the construct of stages of change. The idea that people generally move through different stages of readiness to engage in health behavior changes, whether it's quitting smoking, beginning an exercise, building exercise into your lifestyle, working on diet and diet related to lipid control, alcohol reduction, and so forth. This model has been applied really across a broad array of health behaviors. Our idea was whether this model could be useful in thinking about issues of engagement, participation, and adherence during a delivery of an intervention such as cognitive behavior therapy. So would understanding people's readiness to adopt a pain self-management approach be predictive of their actual engagement in these treatments, their active participation in the treatments once engaged, reduced dropout, for example, completion of treatment, and ultimately the accrual of benefits. So to do this, we developed a measure called the Pain Stages of Change questionnaire. I wish we had called it the Pain Readiness to Change questionnaire to avoid the controversy about the idea of a stage-based model. But nevertheless, our real end goal here was to demonstrate whether this measure actually had predictive validity for those outcomes that I just cited. And this is a slide reminding me to tell you that, ultimately we were able to identify four of the proposed stages reliably, and this has been replicated actually in multiple studies and translated into multiple languages. Frankly, I'm happy to say it helped me travel around the world giving talks about this. It was a great way to advance that interest of mine as well. But the bottom line is that you'll see these kinds of beliefs that people might have. Somebody in the, quote, pre-contemplation stage might leave skid marks showing up at the door of a cognitive behavior therapist because of their belief that their pain problem is a medical one and they should be dealing with physicians about it, to somebody that's actually ready to go and engaged, interested in engaging and learning new skills, or actually somebody in the maintenance stage who has said, I've already learned these things, these skills, and I'm using them in my everyday life. By 2004, a large body of literature based on this idea had already been published, and a woman from Australia and I published a systematic review in a leading pain journal where we showed that the summary of the literature suggested that pre-treatment pain PSOCQ scores, that is lower scores on the pre-contemplation scale and higher contemplation score, predicted treatment completion, in this case mostly CBT, but even other psychological, behavioral, or self-management approaches. That forward stage movement, that is a change in the direction of action and maintenance scores over the course of treatment, predicted or frankly mediated improved outcomes, as well as improved self-reports of pain, use of pain coping skills, and that early treatment stage predicted later improvements in outcomes, suggesting further support for a mediational role of this construct of motivation or readiness to change. And this led Mark Jensen, Warren Nielsen, and I, who have already referenced, who are doing work in this area, to describe a model that we thought could help drive the field further, thinking about readiness to change in this mediation role in leading to improved use of self-management behaviors, or coping, if you will, with moderators such as baseline perceived importance and self-efficacy as important factors in the model as well. And I always like to highlight this study, which was a secondary analysis of data from clinical trials that we were conducting about CBT for chronic pain in the time frame that we were trying to understand more about the role of motivation and readiness to change. and really nicely showed that, in fact, adherence, that is, what people were doing during the treatment in terms of their, at that time, self-reported use of practice of pain coping skills that were being taught during treatment, actually mediated the relationship between baseline contemplation and goal accomplishment as a primary outcome measure. And hats off to Alicia Heapy, colleague who's here in the audience today, for being the lead author on that analysis. And much more recently, in 2014, we actually were starting to publish the results of a large-scale psychotherapy process trial where the endpoint was really studying that intercession adherence and whether we could alter the treatments themselves in ways that could enhance or promote increased engagement in treatment. Well, so those aspects actually failed. We weren't, I don't think it was an issue of power. We really gave it our best shot in trying to match people's preferences for treatment, train providers, to use motivational interviewing skills to promote engagement in one condition versus delivering kind of a standard CBT in the other condition. Really, we had no evidence that kind of tailored or more patient-centered treatment approach actually did promote engagement. But once again, we found very nice evidence that treatment gains were significantly associated with the extent to which people became engaged and actually practiced the skills. So that treatment gains were associated with the dose of treatment that they received, the number of rescheduled sessions, and adherence to therapist recommendations for pain coping skill practice. And this leads me to highlight a very interesting line of research that Alicia and her team is now following up on at VA Connecticut. This is a recently published trial in JAMA Internal Medicine that actually was designed as a non-inferiority trial of an entirely therapist-less approach to delivering cognitive behavior therapy using interactive voice response, that automated system on the phone that we all hate when you really want to talk to a person and you're trying to get an airline reservation and you only have to keep going through all these automated prompts. So Alicia turned that into a system that actually allows people to report on their daily skill practice after really following a treatment manual without an interaction with the therapist, and also to retrieve weekly actually a pre-recorded, individually tailored message from their therapist with whom they never speak, but for whom they have a picture, I think. And in fact, she showed that this automatic approach versus in-person 10-session weekly cognitive behavior therapy was no less effective. And in fact, on some measures, for example, completion of the sessions or attendance to the sessions, actually the people using this system at home did more of the sessions than those that required them to come to in-person treatment. And there was no difference in patient satisfaction, interestingly enough, from in-person to entirely therapist-less IVR-based treatment. Quite provocative for, I think, all of us in the room. So, many years ago, Turk represented a paradox for us. So we have evidence of the effectiveness of these interventions, even cost effectiveness, but we have challenges in terms of being able to understand why they're not in use. Is it just an issue of money? Are there opportunities for improved marketing and changes in policy? And the VA has been a good place to examine this. The VA has implemented by policy a step care model that puts at the ground floor an acknowledgement that this is a population health problem, that pain is being addressed mostly in the home, and that we need to really pay attention to the optimizing pain self-management through their interactions with the healthcare system, mostly given a population health approach at the level of the primary care setting in the VA. We called that the patient-aligned care team, with, of course, timely and equitable access to secondary consultation, specialty consultation and treatment, or even tertiary interdisciplinary pain centers, and the most advanced pain medicine diagnostics and intervention. So this has remained in policy in VA, and actually was one of the models that really ultimately was supported by that earlier evidence synthesis review. And in fact, this is the model that we're implementing in VA and has been shown by self-report, facility-level report data through something called the Health Analysis Information Group survey in the VA, a comprehensive survey of all 140 facilities in VA, and they're obligated to respond, so 100% response rate. What we found was that a large proportion suggested that they were, a significant minority said they were fully implementing this program. Many said another large minority said they were partially implementing, and another small minority were suggesting that they were on their way. And now there'll be another survey in 2018 that we expect that those numbers to be going up. What I wanted to get to was noting that even 3-4 years ago, facilities, when they were asked, what are you doing in primary care, in particular, to support this model, you'll note that psychological, educational kinds of approaches, consistent with this idea of trying to promote the activation of patients and empowerment of patients through education, psychological interventions, in the service of adaptive pain self-management, are actually being rapidly incorporated into VA primary care settings in particular. At VA Connecticut, we had a wonderful award from the Donahue Foundation and the Mayday Fund. Many of you know the Donahue Foundation, a Connecticut-based community clinical research and education enterprise. The Mayday Fund is a small family-run pain foundation. They collaborated in a grant that I was privileged to receive, and we really conducted what we might call an early evaluation and facilitated implementation study at VA Connecticut, where we built an interdisciplinary team of scientists, clinicians, administrator, quality improvement staff, hospital leadership, to really promote uptake of the step care model, particularly focused in primary care, but also the interface with specialty care. And in several years, we really don't see a lot of movement beyond changes in the uptake, really reduction in opioid prescribing and the uptake of opioid risk mitigation strategies. Those are particularly strong. But we did see an uptake in use of physical therapy and chiropractic care, and consistent with our idea of actually reducing the unnecessary reliance on our specialty pain medicine clinic, actually just as we wanted an actual reduction in pain management referrals. This has been taken to a national level, and so much more importantly and impressive, are now looking at national data on the uptake of non-opioid pharmacologic approaches and non-pharmacologic approaches, as well as opioid prescribing and long-term opioid therapy prescribing in particular. The only two things going down are opioid prescribing and long-term opioid therapy prescribing, and in every other instance we see a graduated uptake and significant uptake across the board in other non-pharmacologic approaches and non-opioid approaches, consistent with the step care model and really what I'm talking about today. In VA, there's a lot of other work being done really to promote pain self-management, including, I'm going to highlight just very briefly, a mental health service line, evidence-based psychotherapy initiative, and pushing out a cognitive behavior therapy for chronic pain, a national telehealth initiative focused on pain, and a few others. So very quickly, in terms of the national dissemination effort, this is a very intensive training program, training mental health providers from any specialty mental health setting, including integrated primary care settings in the VA, to actually be trained in high fidelity delivery of cognitive behavior therapy. At the time of this paper, now a few years ago, 171 VA clinician participants had received this training, and 79% of them actually had completed all our endpoints in terms of fidelity ratings. And these patient level data come from a sample of about 170 people in terms of reductions in pain, showing reductions in pain intensity ratings and pain interference ratings. This is a snapshot of a work that's being done at VA Connecticut to deliver cognitive behavior therapy via remotely, in person, if you will, but face-to-face, but not in person, using high-speed video conferencing, and showing overall satisfaction with this kind of approach and significant reductions or improvements for a significant proportion of the recipients of this intervention. I want to close by highlighting the work of our Prime Center, the Pain Research, Multimorbidities, Pain Research, Informatics, Multimorbidities, and Education Center at VA Connecticut, a VA Health Services Research and Development Center of Innovation, with goals that have a specific focus on pain and pain management, and in particular, the promotion of novel interventions, and all in the support of improving pain care for veterans. Quickly, there are multiple studies and people that I'm going to run through that are most of these are works in progress. This is a project that I'm involved in with Diana Higgins, formerly of Yale, but now at VA Boston and Boston University, trial funded by the VA Rehabilitation Research and Development Service, and preliminary data on development and piloting of a web-based pain self-management intervention informed by a CBT-like approach. A similar kind of project with an industry partner, actually the current CEO and president of the enterprise ProChange that was developed by Prochaska originally. So we actually just received a second phase small business innovation research grant for the National Center for Complementary and Integrative Health to continue this work to develop a very high level, I'm impressed with the quality of this web-based program focusing on not only pain, but sleep hygiene and stress management, targeting actually veterans, but not expecting to interface with the VA, but veterans in the community more broadly. And our results from the pilot were actually quite promising in terms of not only satisfaction and engagement, but preliminary outcomes. Mary Driscoll, who's in the audience, has a new project funded by our region, our VISN VISN Research Enterprise, really to take a novel approach to helping women veterans through a reciprocal peer support approach to really helping guide women, pairs of women with chronic pain to work together through the use of technologies like text messaging or the phone to support each other in working through a manual related to pain self-management with the opportunity to interact with a nurse from the women's clinic on a monthly basis, on a drop-in basis. So that's exciting and just underway. And another junior faculty here, Sarah Edmond, has a similar funding from the VISN, and she is developing the idea of applying a shared medical appointment model in the primary care setting to bring groups of veterans who are in receipt of long-term opioid therapy without evidence of aberrant behaviors or opioid use disorder to really, through a partnered approach with the primary care provider or nurse and a behavioral health specialist, in this case a clinical psychologist, to promote the ideas of a biopsychosocial approach and uptake of non-pharmacologic approaches. Alicia and Will Becker from the Department of Internal Medicine have, frankly, an implementation science project that's focused on really seeing if we can study the implementation methods to promote the uptake of her COPES-based intervention or Will's what's called PIPS, Primary Care Integrated Pain Support Program, that targets veterans on high-risk opioid medications, also with the eye to promoting uptake of non-pharmacologic approaches. And I'd also highlight work being done by other colleagues in our center focusing on the interrelationships between pain and chronic pain and overweight, obesity, and diet, and also tobacco use, all in the service of really trying to promote uptake of or improve pain care. And lastly, I want to acknowledge that we just recently found out that we were funded here at Yale and VA Connecticut for what's actually now the Health and Human Services DoD VA Pain Management Collaboratory, an $81 million investment on the part of those organizations to promote the uptake of non-pharmacologic approaches through the conduct of 11 pragmatic clinical trials. These are clinical trials to be conducted, embedded in clinical practice settings, with mostly reliance on the clinical practice workflow and collection of data in the electronic health record as outcomes. And so we'll be studying whether really taking the kind of work that I've been talking about to the next step and thinking about really the pragmatic challenges of implementing them in clinical practice settings. And 2 of the 11 projects are actually granted to PIs in this department, Alicia Heapy and Mark Rosen and Steve Martino. So where do we go from here? Having said all this about the science, I think some of the biggest opportunities are really getting to the media and really promoting a public health campaign. And it's gratifying to see that even in the context of the big media frenzy around the opioid epidemic, that pain management on its own is getting some of its due through recent publications in the Scientific American and Consumer Reports, who have picked up on this model. And I think investing for us in this community, investing in reaching the community and people with pain is an important opportunity for us that as yet we haven't taken fully advantage of, but I think we can. And ultimately, like my grandson Jonah, who I'm very proud of and we'll see later today, we all have a lot of work to do. And with that, I'm back on my horse and I say thank you.
We have time for 1 or 2 questions.
Good.
Well, I have one. It seems to me that in this area as well as other areas of CBT, our goal might be to try to increase completion of the sessions, the practice programs we have, and how do you think about doing that as an intermediate target that would translate to downstream effect?
So I think that's really important, and I think that's true maybe about these other interventions. I think the work that Alicia is doing and others in terms of addressing this at the point of access and trying to find technology solutions, reducing the burden on patients, and also, frankly, accepting the reality of we have a problem in terms of number of competent providers to deliver these services, and a healthcare reimbursement model that really doesn't help that situation. So I think right now, a big focus that we're doing at the Prime Center, that Alicia and others are heading, to think about the use of technology. Of course, that's fraught with its challenges as well. I have to say, we live in a very privileged, we're privileged people to be here at all, privileged in this environment. Yale New Haven Hospital, great health care. There are large swaths of this country that live literally hundreds of miles from the nearest trained psychologist. And that's true in the VA, but it's true in the private sector as well. And then, recent studies pointing out that wealth is an issue, that certain, the economic disparities in this country are huge challenges as well. I think even for them, a small investment in, a cell phone to help people be able to connect to healthcare providers remotely can help to address those challenges. So that's not the full answer, but it certainly is part of the picture. Yes?
First of all, Bob, this is a beautiful expression of a lifetime of work that has touched and will touch millions of lives. It's not too many of us can look back on our work and say that we are affecting the lives of millions. And I think that you can feel that, and it's a wonderful thing.
Thank you.
I've lived with, watched the sort of curve of the way pain has been treated. And I remember early on, it was a big deal when pain became one of the vital signs that everybody was supposed to take. We were going to, and there are the charts with the faces on it to express, how severe is your pain. David Spiegel came here and spoke in Grand Rounds and had an interesting critique about that. He's, as you know, got a hypnosis background, and he felt that was a terrible thing to do, that it suggested that you had this problem when maybe you didn't really quite think of it that way. And he said, why couldn't they just say, how comfortable are you? What is your level of comfort? And do you think that in some way we are responsible for having created this sort of focus on pain by that vital sign approach?
Well, it's certainly been harshly criticized in the way that you just described. Not so much could there have been a better way of framing a similar question. I think at the time, it's important to think about even the historical context that led to that. At that time, state initiatives were popping up across the country challenging the problem of people dying in pain, unnecessary pain in this country. And that extended to the broader issue of chronic pain. That in our culture, which is, our multi-ethnic, multiracial culture, still the dominant themes are things like put up, shut up, no pain, no gain. And that the challenge was that we understood that pain was present in people's lives and affecting their lives in much greater numbers than was being represented in the, presented to the healthcare system. People were living in silence, so to speak, and that was a tragedy that needed to be addressed. And so that was the impetus, I think, for the Joint Commission who launched that initiative and the VA who had quickly adopted it. In hindsight, was it a problem? Did it actually contribute, as many have said, to the opioid epidemic? Because at that time, and maybe today, we still have so few things in the toolbox other than the prescription pad to address people's pain. But we also have a culture that still is very much about going to a doctor. Pain is the problem. They're kind of stuck in an acute pain model. Pain is a problem that says something's wrong, I need to address it, and so forth. So I think it's complicated. It is an important historical fact. I think now there's a very strong interest in moving, and Joint Commission is, I think, taking a step toward this. The VA, I think, is just on the cuffs after many years, trying to think about broadening that measure to not just pain, but a measure of impact and functioning and bother, emotional distress, and zooming in more on it being less of a screening tool for all pain, but really helping to better measure chronic pain, which limits the scope, but may help address the big elephant in the room. We're not quite there yet. There's still many people, particularly pharma, drug companies, are objecting to the idea of thinking they have to, despite commercials, sorry for a little getting on my grandstand, but commercials about the dancing person. You take this drug and you'll be dancing too. It's all about analgesia, and they want to study analgesia. And major initiatives in the NIH and the recently announced public-private partnership of Francis Collins and Nora Volkow around analgesic drug development, really, still is mostly just that. So there are many challenges to do what I think, and maybe you're suggesting, is the right thing to do, but we're not there yet. So I know we have to stop. Thank you all very much, and thank you, Morris.